Thank you, Bruno. Thank you, Sanjay. I think Sanjay clearly wants to be the only Sanjay bariatric surgeon, so that's why he made me Sanjay on the program. But thank you very much for that. Thank you for inviting me. It's a real privilege and an honor to be able to speak with such huge names in bariatrics. I have some disclosures, most of which will become more and more apparent as time comes on with our NHS debacle. I'm sure all of you will agree that work in the UK. Importantly, none of my disclosures have anything to do with buttressing or staple line reinforcement. So, we've heard about the morbidity of sleeve. We've heard about the fact that there are more sleeve gastrectomies occurring across the world. And we've heard that leaks can be absolutely devastating. Most of them tend to be proximal. And there are lots of surgical strategies. And I'm not going to sit here and try and debate that the only thing that will make the sleeve complication reduced is using buttressing or staple line reinforcement, because there are many different things. And Sammy, who's my current fellow sitting over there, is probably fed up of hearing these things when I'm in the operating room. But why should we consider buttressing? Well, we rely on staplers. They've improved, they're continuing to improve, but we don't really understand exactly how they work most of the time as their development evolves. They're intelligent staplers. There are different staple heights, there are different manufacturers, there are different speeds of firing your stapler. So we rely on this technology to avoid the complications of the staple line, because without a stapler, you can't do a sleeve. And for that reason, I think that buttressing is important. There are lots of different forms of staple line reinforcement. Stitching, glue, and all of the different bioavailable, absorbable networks that absorb at different rates in different ways, and all the manufacturers will tell you the pros and cons of those. We've heard about bleeding and leak. They can be devastating. They tend to be the two things that we want to avoid the most with sleeve gastrectomy surgery. But you can get strictures, and all of these complications are painful for the patient, us, the team. I've got my specialist team sitting in the audience somewhere. They will definitely tell you about that. The healthcare system, which is broken in this country, in the public sector, and most of all our specialty, because these are the sleeve leaks we hear internationally and nationally that make the media and the press that then say bariatric surgeons are crazy for doing this operation on me. What do I use? I use a Signia iDrive, black and purple cartridges, seam guard, a 34 French bougie without stapling tightly onto it, and a ligature. So that's what I use. Let's talk about the evidence. Bleeding. There has been evidence out there to suggest, from randomized and non-randomized data, in vivo, in vitro, human, animal, to suggest that buttressing definitely reduces bleeding rates. 2004, 2011, 2010, big names, decent journals, good impact factor. 2018, 2019, and the most recent paper from Cunningham Hill, basically 200,000 patients nearly, and it suggests that staple line reinforcements significantly reduce the bleeding and the reoperation rate. Huge numbers, decent stats, excellent follow-up, prospective data set with low heterogeneity. I don't think it's easy to disclaim that evidence. So that's bleeding. Leak. Animal studies. So Dr. Shikora and his colleagues looked at porcine models, and the burst pressures are significantly higher if you use buttressing compared to not in animal studies in vitro and in vivo. This data was then meta-analyzed by our Chinese colleagues. Several studies, 8 of them, RCTs, nearly 800 patients, and it showed that there was no difference in leak rate, but most importantly, no worse outcomes, which is what I'm sure Kalpana is going to argue against when she gets up here to try and take me apart. Further systematic reviews, this time by our colleagues down the road at St George's, 9 studies, and staple line reinforcement significantly reducing the leak rate, but not bleeding in their case. So some of these results seem heterogeneous, and it all depends as to which data you pick and how you statistically analyze it, or so we think. Further evidence about leaks. So 2 randomized studies, 6 cohort studies, again, reduced leak rate. Michel's paper, 148 studies, 5 methods. Overall leak rate, 1.5%, which is what all of our colleagues have shown today, and that if you compare no staple line reinforcement to the best staple line reinforcement, it's a no-brainer. Meta-analysis from Scott Shikora. Again, look at the difference. No reinforcement compared to reinforcement. One of the problems, which again I'm sure Kalpana will highlight, is all the different forms of staple line reinforcement are different. And so they are all pulled together. So if you look at the meta-analyses and you want to do it properly, and I've done a lot of these in my time, they are heterogeneous. But if you look at the individual different types, and I use the one I choose to use because I feel that is the safest for my patients, you will see the difference between no buttressing and buttressing for bleeding and leak. Another paper, nearly 10,000 papers. Again, look at the difference between no SLR and absorbable polymer membrane, that's basically seam guard. And finally, this slide basically caps it all off. If you are going to do a sleeve gastrectomy, and it's interesting to see that some of our colleagues are putting patients off, and I think one of the best strategies for not having a sleeve gastrectomy complication is to just not do it. But this slide says if you're going to do it, use staple line reinforcement. Kamal's in the front row. He's always publishing. That's his study. Even with all this evidence, only 54% of the 863 people that emailed Kamal back for his recent survey used staple line reinforcement. The recent MBS AQUIP data, 180,000 patients nearly reduced bleeding from staple line reinforcement. You know what I use? What do I tell Sammy? Do it nicely, don't kink it, don't twist it, don't touch the staple line, do a leak test, which is, in my opinion, not really a leak test, but a bleeding test. Make sure the operation looks immaculate while you're doing it and at the end. And post-operatively, manage their blood pressure very carefully. But please use SLR if you're going to operate with patients with my name over their bed. Low leak rates. They should be getting lower, and hopefully they are, but they should be never events. One leak is a disaster. One leak is a plane crash. One leak is an explosion in Chernobyl. And that's how we should be seeing it, not as 3% of 50 million operations that are going to be done worldwide globally. The evidence that I've shown in the last slides shows very clearly that bleeding and most likely leak-related complications are significantly reduced with SLR. So why don't you use it? Some people don't use it because they say it takes longer. That may be oversewing, none of the other causes really. As surgeons, we are risk averse. We're a bit like drivers. Sometimes we're waiting at a traffic light and we need to get to work or home or wherever, and we will take that risk of getting that red light ticket or speeding. Is it worth it for your 3 or 9 points? Is it worth it for the leak? I don't think so. Cost I'm going to come to in a second. There's no evidence that there's worse pain. There's only one abstract I could find in the literature about strictures, and that was with fibrin glue. No evidence that there's worse adhesions. The cost of one leak ranges from €7,500 to nearly €100,000. One leak compared to the cost of a bit of buttressing. Why do I use it? I'm a bit biased because I always have. Pointed at Charing Cross, then working at Mary's, always used it. It stops me and my fellows from touching the staple line. When we didn't have some stock because there were some hurricanes in a few places and sterilization issues, we had problems. The staple line doesn't look nice and we had more bleeding. We have had 4 sleeve leaks in a decade, 2 primary and 2 revision in our center. And my hospital will accept the cost of buttressing, but it will not accept the cost of multiple complications, particularly in the austerity times of the NHS. So why do I use it? I'm very fortunate. I've been a consultant for 10 years, 8 years at the St Mary's site, and so far haven't had one. But then again, I do more bypasses than sleeves. 2 reoperations, 1 for bleeding, 1 was without, and 1 with, and that's the data. Can you have a perfect sleeve? Only if you don't do one. And these are the people that have helped me with this talk. Sammy, who's suffered and loved the pain for so long, he's staying for a 2nd year. And Simon, who's been my ACF for the last 5 years. Thank you very much.
Thank you. Thank you very much, Sanjay. And I will call Kalpana to present against the regular use of staple line reinforcement.
How do I get this?
She tried everything, it doesn't work. We're using that one.
Something happened.
Okay. I'm losing time, so I'm going to carry on while we are fixing the computer. Thank you, Sanjay, for your fine talk. I will address some of the points and counter in my presentation. Now, most people fear that a loss of losing $100 compared to the hope of gaining $150. And this is a statement from famous Nobel Prize winning psychologist Daniel Kahneman, who most of you would have heard of. I can see a lot of anxious faces. Don't worry, I'm not here to give a talk on human psychology. But what I'm trying to say, as Sanjay already alluded to, most people are loss averse or risk averse by nature. And so are we. As surgeons, our biggest loss is having a complication. There's a fear of litigation, blame, shame, and fear of losing your reputation. And therefore, surgeons have a low threshold of using all the available resources. And if you work in a rich trust like Sanjay, use everything available on the shelf to reduce the complications and to achieve the ultimate goal of improving patient outcomes. So as we're talking about complications in sleeve and gastrectomy, we're mainly referring to the leaks and bleeds. And as we've already heard from the lovely talk Prof. Weiner gave us, over the last decade, there has been a the results of sleeve gastrectomy have significantly improved in terms of lower morbidity and mortality. And this is largely due to increased surgeon experience and, of course, the improved stapling designs. Again, Sanjay has the best stapler, the latest technology available to him. And that is one of the key factors which has helped us in reducing the leaks and bleeds in sleeve gastrectomy, and this itself obviates the need of using buttressing in sleeve gastrectomy. Now, when we're talking about the complications and leaks in sleeve gastrectomy, we obviously have to consider several parameters, as again, it's already been mentioned that we're not just looking at one thing, buttressing. There are many other factors which contribute to the outcomes of sleeve gastrectomy, such as there's a huge variation in practice, the type of stapler used, stapler cartridges, in terms of staple heights, and also the size of bougie, the distance from pylorus, and obviously there are, and whether if somebody uses or you choose to use a reinforcement technique, that's fine. That's fine. I don't have that many slides. I don't have as many slides as Sanjay does, so I'm not ready for that yet. So what I was saying is, obviously, we're talking about the number of parameters and variations in practice. And of course, you may choose to use some reinforcement techniques, which could be just suturing or glue or clips, if there is a concern when at intraoperative inspection of the staple line or at leak test. And again, if you have buttress product on the shelf, yes, you may use it. But what is the most important thing? In my opinion, it's the surgeon experience. How experienced is a surgeon is the key factor in determining the outcomes of sleeve gastrectomy. Now let's mainly focus on the buttressing, as that's the topic of the day. And I would like to mention, which obviously this is, which Sanjay is obviously going to counter me on, but it is one of the largest studies of analysis of prospectively collected surgical techniques was published in the Annals in 2016, the impact of different surgical techniques in the outcomes, and it's the first report of the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. And why is it important? Because it is one of the, as I said, already mentioned, largest studies, largest bariatric nationwide registry, which included just under 190,000 patients across 720 centers in the States. And what did it show? It showed that buttressing actually increased the leak rates in sleeve gastrectomy. Now, how does this work? Well, the hypothesis is that buttressing material, which is thick, obviously increases the thickness along the staple line, which may result in poor staple formation and height. There are several other studies, as Sanjay already showed some of my slides to you, which support that buttressing does not have any major impact on changing the complications in sleeve gastrectomy. There are a number of systematic reviews. I'm not going to go through each one of them, but large systematic reviews by Parikh and his group studying just under 10,000 patients. Buttressing did not have any impact on the leak. Knaps and his colleagues looked at another about 5,000 patients, another systematic review and meta-analysis. No difference with or without buttressing. Then we have a few more which have shown similar results. And the list goes on and on. Just as we have the pleasure of having Dr. Himpens in the audience today. And Dr. Himpens may remember that he had been part of a randomized control trial, which again showed the same results as comparing non-buttressing, non-reinforcement versus suture versus buttressing, and did not show any significant difference in terms of complication rates. And not only did it not show the difference, it increases the length of the operation, the duration of the operation, and the cost of surgery by almost 1,000 euros. So, is it really needed? In our own experience at Homerton, of looking at 1,000 consecutive patients, which we presented at the IFSO 2019 World Congress, I didn't put the slide up, but we had one leak along the staple line in the 1,000 cases, and one cannot justify the use of buttressing because buttressing will not eliminate the risk of having a leak completely, even if it works. The literature on buttressing has conflicting results. However, there may be a place for selective reinforcement using sutures, clip, or maybe seal if there is any concern at intraoperative visual survey of the staple line or leak test. I just want to counter some of the points which Sanjay raised in this talk. He showed us the slide on the systematic review by Garnier in 2019. It is the nature of the review method relies solely upon the data provided by the publication, and that's why there's several limitations of systematic review which we have to consider. That particular review only had one RCT. There was no granular data included regarding use of reinforcement, whether it was used entire staple line or whether it was used only for the part of the staple line. We don't know whether the buttress material was used on the either side of the cartridge. What was the stapler type? What was the staple height? There was no data regarding, consistent data regarding leaks and bleeds, and they were all collected as free text. Staple height selection was not uniformly collected, and this may have been a significant factor with staple line leaks, which is acknowledged in the paper itself by Prof. Garnier. Again, we also talked about the advances in stapling technology, and this itself can produce a knowledge gap in surgeons' understanding of how the devices interact with the tissue. And surgeons often fall back on their own judgment or rely on anecdotal evidence, which may translate into suboptimal outcomes. And I think we should focus more on educational programs to inform and update surgeons on the characteristic of each stapler rather than resort to buttressing, which actually increases the leaks in sleeve gastrectomy. One more point I would like to counter is the burst pressures, as you mentioned, Sanjay. We have enough evidence in literature that the use of reinforcement it does increase the burst pressures, but it does not prevent leaks. There is no correlation between the burst pressures and the leaks. And there was a study published by Edin, which again proves the same point. And not only it adds to the additional cost of surgery, but as we've seen, may also cause increased leaks. So now going back to where I started, as surgeons, we need to overcome our fears. And it is paramount that we are introspective about the work we do. There is no high-quality evidence to support the notion that buttressing reduces the leaks in sleeve gastrectomy. And therefore, Chairman, ladies and gentlemen, we should and we must avoid unnecessary, routine, precautionary use of buttressing in sleeve gastrectomy.
Thank you very much, Kalpana, for presentation and cross-examination. Now it's Sanjay time. Very quickly, please, if you want to cross-examine Kalpana's presentation.
Sure. Should I take a mic? Thanks, Kalpana. I heard you were formidable, and everyone was absolutely correct. So in the interest of the debate and time, from the pro perspective, with regards to the buttressing actually causing more complications, quite rightly, Kalpana has to actually get granular with that data too if she wants to get granular with the rest of the data. So the granular data shows that there is one in particular buttressing material that was probably the cause for the increased complications, and that was subsequently in one of the slides that I went through very quickly, which was one of the bovine pericardium elements. If you take that out as a subgroup analysis, you will find that that study doesn't hold water any further, but it also means that it becomes less powered and less numbered. Have I seen any data to suggest that buttressing causes loads of complications? The answer is yes, but it's only in the budget of the hospital. And she's right, I work in a very rich trust, which is only £800 million in debt. So I'm sure that that is just as wealthy as this amazing foundation trust, because we are not a foundation trust, okay? With regards to reality, there are 1 billion ways of getting from A to B. And I put up a first slide because I'm not a kind of person that will say you can only do one thing well in one way. It's horses for courses. And you will learn the recipe for the best sleeve in your hands as a surgeon, as a unit, as a trainer, and as a trainee. So if Kalpana and Sanjay and his team have found a way of doing this, like this, with 1 leak in 1,000, they should carry on doing it. We found a way of doing it well with very little morbidity, mortality, leak, and bleeding, and we will continue to do it that way. So in the interests of the debate, thank you, Kalpana, because I think you had a harder task than I did. I think the jury is still out, and I think the real answer to who ends up using buttressing will remain with Kamal, because he's the guilty party here, because he will tweet, Facebook, and digitalize all of your opinions that will tell us how many of you decide that Kalpana's right or I'm right. Thank you very much.
Very quickly, let's see how many surgeons in the audience use regularly staple line reinforcement for sleeve gastrectomy. Clearly a minority. And the same thing for all the other bariatric operation. Is there any difference in practice between sleeve and any other bariatric operation? Do you use staple line reinforcement for bypasses, bleeding gastric bypasses? No. So even the one who raised their hands for a sleeve, they don't use the staple and reinforcement for the other operation. Thank you.
The only one we published in surgical endoscopy of the studies, the bleeding, the bleeding frequency and the rate of bleeding is the only thing is decreasing. If you're doing a high volume program and you have to do 15, 20 cases a day in a hospital bariatric, then it's very helpful to lower down the frequency of bleeding. And this helps. Also the MGB, the long staple line, we are using in buttress.
Okay, thank you. Thank you, Sanjay, again. I think you should reconsider the use of buttressing as the trust is in such a death and economic crisis. I think it's a really sorry state that you're still continuing to use buttressing and it's rather helping your trust out. There are a number of studies in literature which have showed an increased cost of buttressing. If you look at the French study, it showed a cost of about 750 euros it adds to per case. And another study from US, where Prof. Garnier himself is a co-author, established about a $1,000 increase per case with buttressing.
Michelle uses gold-plated buttressing. Very expensive.
I think if you have a gold-plated budget, it probably suits you. But I think in real world, and especially in the current economic crisis, considering how the NHS is in the current day and age, I think one should reconsider and not continue to use buttressing when you have results which are equivalent without buttressing. You also mentioned about the bovine pericardium included in the study, which the NBSA QIP study, and also the other the different products which have been used, which are no longer in use. But if you look at the Shikora study, which you actually highlighted, he actually showed that, and it was a much bigger study, about 42,000 patients, and bovine pericardium outperformed the seam guard as you are using. And there are a number of other studies which support bovine pericardium is better than seam guard. So how does one know which buttressing product is superior? Actually, they're all causing increased leak rates, in my opinion. Now, again, I think you didn't really elaborate on the cost, because you pretty much know that actually it is a high cost of managing leaks. But if your leak rates are as low as they should be, and I think in a majority of high volume centers, I would think it would be the same as ours without the use of buttressing. We are not really glorifying our own results. This is normal. And it doesn't justify the use of buttressing given the cost of the buttressing product and the risk that we would be taking in promoting leaks by use of buttressing. I think I've counted all your points now.
Thank you.
I have a few more things to say.
May I make a comment?
So I think I just want to wind up by saying that laparoscopic sleeve gastrectomy is a safe procedure with low morbidity, and therefore we know that RCTs are not feasible. I think the experience of surgeons is critical in optimizing the staple line integrity and staple cartridge selection, which are keys to prevention of leaks. The heterogeneity of studies, the small statistical power, the discrepancy of buttressing material used, in conjunction with varying staple heights and techniques. And for the very reason POMS or ASMBS position statement itself does not recommend routine use of buttressing. There is no high quality evidence to support buttressing, and therefore mandated use of buttressing is not indicated. So, Chairman, ladies and gentlemen, I hope you all agree with me that Dumbo's power to fly and our power to produce great results in sleeve gastrectomy do not come from any magic feather or buttressing. And I leave you with this slide.
Thank you, Kalpana. Can I make a comment, please? Obviously, Sanjay, Kalpana works with me, so I have to be biased and I have to support her. Two things we can do to help you to reduce your debt in the trust. You can come and get trained by us, or you can send your team to Homerton, and then we can tell you how to do sleep astronomy without a leak, and you can learn from our experience and go back and tell your team.
Always prone to coming to see other people who do other things.
Thank you.
Shall I bring it up here?
Thank you, Kalpana, and thank you, Sanjay, for the great debate. And microphone to the next speaker.
Okay.